Dr. Randall Wolf here. Welcome to DEBAKEY CV Live. All these programs were started by Dr. Lumsden, the head of DEBAKEY Heart and Vascular Center. And one of our foci is atrial fibrillation. And that's what we'll be discussing for the next 60 minutes. You're on DEBAKEY CV Live, Houston, Texas. We have an exciting program, and it is interactive. It is live, as it says, DEBAKEY CV Live. CV stands for cardiovascular. So if you're listening and you have a question about AFib, either for me or one of my guests, you may text it to 37607. 37607 on your phone. And then in the text box, put DEBAKEY, DEBAKEY, and that'll get you into our system, and you may ask any question you like over the next hour. I would encourage you to ask your questions before the end of the hour, so we might get to them. So on your phone, go to 37607. In the little text box, put DEBAKEY, and the instructions will allow you to text us your questions. If you're on a regular computer, you can go to pollev.com, and we'll be showing this from time to time, /DEBAKEY. That's POLL, like taking a poll, and then the letter E, and then the letter V as in Victor.com /DEBAKEY, DEBAKEY. Now, we host this once a month. It's the first Tuesday of the month, and that is what today is. Happens to be June the 1st. Last month, we had on Mr. Godfrey Klaber, and we had a really interesting discussion. We had a little issue getting the questions to come up, and there were about 25 questions. So I asked Mr. Klaber if he'd be kind enough to join us at the beginning of this program to answer the questions that we did not get to at the last program. Then I also have here Debbie Simpson with us. Debbie is from Lakewood, Washington. She is an Army nurse practitioner. She worked in trauma, critical care. She worked in the Wounded Warrior Clinic. Very interesting lady. And she will tell us her story of AFib. But first, let's finish up what we started last month on the first Tuesday. First of all, Mr. Klaber, thanks again for going the extra 9 yards and coming on again after last month. I really appreciate it. And I hope you're not muted, so I hope we can hear you. So let's go right into the questions. The first question, and this was for Mr. Klaber. And by the way, for those of you who may not have joined us last month, Mr. Klaber was our guest in May, and he had the Wolf Minimaze 17 years ago. And he has been free of AFib for the last 17 years and off medications. So the first question from last month, Godfrey, was, did you notice any strength or other improvement in your health after you had the Minimaze procedure? I can't hear you, but I hope the producers have it so they can.
Yeah, I'm back here now.
There you go. Okay, go ahead.
Yeah, I had unmute here. Yes, life was much more interesting and better. Just a great improvement.
Did you think you had some improvement in strength when you got back into rhythm?
Yes.
Okay. Now, second question is also for Mr. Klaber. One of the people who watched last month wanted to know if you took any supplements or vitamins before the Wolf Minimaze procedure.
Yes, I did. A long time ago, I listened to a person talking about vitamins, and my wife and I have taken vitamins most of our life.
So you took those before the procedure and continued them afterwards, I take it?
Yes.
All right. The next question for me, was directed to me, and it was a question: women versus men with the Minimaze. Do women do better? Do men do better with the Minimaze? And the answer is they both do the same. But it did remind me there is something that does make a difference, and that's the size of the patient. Some of you may be familiar with BMI, which is your height and your weight combined. And if the BMI is over 37, then it's technically a little more challenging procedure. I'm working through little incisions with a scope. I do not put my hand inside the body. We do not stop the heart. So on bigger bodies, the distance between the skin and the ribs and the heart can be increased quite a bit. Now, I have done patients with a BMI as high as 50. So it also depends on the distribution of the weight. Many people have more weight in their belly or their rear end and not that much in your chest. And that's an advantage for a minimally invasive procedure. But still, the thing that seems to make the most difference as far as quick recovery, as far as having pain and discomfort, is the size of the patient. Mr. Klaber, you're pretty normal size. After the procedure, were you able to increase your activity fairly quickly?
Oh, yes. I think I had the procedure in early January, and the 28th of February, we were on our way on a cruise.
Okay. And that was 17 years ago, I guess,
yes.
Or close to it. So I think the biggest thing is not whether you're male or female. And by the way, another question that comes up related to that is women ask, well, I've had breast implants. Is that a problem? We've never had a problem with that because the way to get to the heart are behind the breast. So I've done countless women with augmentation, implants, reconstruction, mastectomies and reconstruction, and in no time that ever affect me doing the procedure, doing the Minimaze procedure. The next question is for me as well. It's I had mentioned that Atrial, which is the company that I helped get started based on the clamp idea, and this was with Mike Hooven, who was the electrical engineer who designed the clamp and started Atrial. I mentioned that it's sold around the world, but the person who asked the question had the impression that Minimaze was only done by me in Houston. Well, that's a very good question. Let me clarify. There are many types of procedures that are called Minimaze. But as far as I know, I'm the only one in the world who tests the nerves. And this is very important. I have a fundamentally different approach to AFib compared to burning the inside of the heart. The key is to interrupt little nerves on the outside of the heart that are the initiators of AFib. So instead of destroying a lot of heart tissue by burning or freezing, the key is to go to the outside of the heart and test and ablate the nerves. As far as I know, I'm the only one who does that. There are other people who do a version of the Minimaze, but I do not think they test and specifically ablate the nerves. And that's really the key to getting rid of the initiation of AFib. I've had many people tell me that after the Minimaze procedure, they feel like they're going to have an episode of AFib, and it never happens. And that's because when those impulses come from the vagus nerve, they don't get to the heart and they don't go out of rhythm. Now, next question is for Mr. Godfrey Klaber. One of the callers mentioned that you had been AFib free for 17 years, and they asked they were incredulous. They said, you've had no AFib events in 17 years, sort of baiting you a little bit, I guess. So could you answer that question for the caller from last month?
Well, I have not had AFib. I did have some tachycardia, I guess, about 2 years ago. I'd been out using my snowplow, moving some dirt, and I ate some things that I shouldn't have. And you know, the vagus nerve services the gut and the heart both. And I went to the hospital. They gave me a couple of cardias, and that's all. I think I took 3, and I haven't taken any since.
And that's your one event in the last 17 years, and that wasn't AFib. Is that correct?
Right.
Okay. I like that answer. The next question is for me, and it's a question about how about after the Minimaze procedure for AFib, what about recurrence of AFib? This is a good question, and we could talk a whole hour about this. I'll summarize it succinctly by saying that, yes, there is a treatment if there's recurrent AFib. This generally happens in patients who've been out of rhythm for more than a year, sometimes as many as 5 years, and who have a very enlarged left atrium that is greater than 5.5 centimeters, which a measurement of one of the chambers of your heart. Now, usually what comes back is flutter and not fib, but it can be fib. We now have a series of patients who've been in this situation where we've done a hybrid procedure where we go back with a catheter and find the areas where the flutter or the fib are occurring, which is outside the area of the Minimaze procedure. And so far, knock on wood, that's been 100% successful in getting patients back in rhythm. We've never had to redo a Minimaze. A Minimaze is a one and done. That's why a lot of people like it. You don't have to take blood thinners after the Minimaze. You don't have to take other medications for your heart. So that's been a big advantage of it, but nothing's 100%. If a patient has AFib that comes and goes, there are 95 chances out of 100 that you'll be in rhythm 6 years after the Minimaze with no medications. If your AFib is continuous and has been continuous for over a year and the left atrium is enlarged, then the success goes down to about 75 chances, which is still very good. And if it does fail, then we can go back with a catheter, as I mentioned, and find a place that maybe is outside the Minimaze that's causing some flutter or fib. Next question was, talk more about the clamp. And this is actually a very good question, and it goes to the technology of the clamp. And that is, when the clamp is closed, the electrical signal simply goes from one side of the clamp to the other. So it's incredibly safe. There's no possibility of injuring the phrenic nerve or the esophagus, which can happen in a catheter ablation. With most catheter ablations that use electricity, a grounding pad is somewhere else on the patient, usually on the leg. So the electricity has to go from the tip of the catheter through the path of least resistance to the leg. With the Minimaze, it's not like that. With the clamp, the electricity only goes from one side of the clamp to the other side. That's it. Additionally, and very importantly, when the clamp is closed, there's no blood there. And with a catheter ablation, the blood is either being frozen or boiled around where the catheter tip is. And that creates a lot of heat. That heat is dissipated by the blood. That also causes little bits of tissue and coagulum to go to the brain. We did a test in patients who have a catheter ablation, 2,000 to 4,000 little bits of stuff go into the brain with each ablation. With the Minimaze, 0. And it's because we're not in the blood. When the clamp closes, there's no blood there. And that also means we get a transmural all the way across the muscle application in less than 12 seconds, whereas a catheter ablation, you just can't do that. So the clamp is the key. And in situations where surgeons offer additional lines, if those additional lines are not made with the clamp, they don't matter, because those additional lines won't be all the way through the muscle. Another question is for me, does the vagus nerve affect AFib or vice versa? The answer is the vagus nerve causes the AFib. It's an imbalance of the autonomic nervous system. Interestingly, some people that have AFib and stomach troubles, as Mr. Klaber mentioned, the vagus goes to both. The stomach problems get better after the AFib is taken care of. So it's the vagus nerve is an initiator, and we know this from the animal model. You can put an animal in AFib. If you inject alcohol around the little fat pads on the outside of the heart, the AFib goes away like that. So we know that modifying the vagus nerve stops the initiation of the AFib. It's not the vice versa. Now, the next question was not really a question, it was a comment, and it came in from Michael Klaber, and it said, Godfrey is my father. I want to thank you for giving my father and our family back a quality of life that he would not have enjoyed with all of your efforts. God bless you. So, Godfrey, I want to thank your son for that kind comment. And I think when he says efforts, one thing that I know about is I started off in the lab and I did hundreds of animals and cadavers before we ever did these procedures. So, and I designed these instruments. So I'm not only involved in the surgical part, but also the design of the technique and the design of the procedures. And I've tested all these devices in the animal model until they were perfect. Another question was about Medicare HMO. Does Medicare HMO cover Wolf Minimaze? Some of them do, a few do not. The only way to tell is to contact us. We do for free. Ask your specific insurance coverage if they do. Of course, Medicare, plain Medicare, covers the Wolf Minimaze and has for many, many years. But some people have additional policies, supplemental policies, and those may or may not. The supplemental policies covered 20% of Part B, which is the fees that are outside of the hospital. But we always check for everybody. We've never asked someone to come to Houston before we've made sure that the coverage was adequate. So I just went through about 20 minutes of questions that we did not get to a month ago. Godfrey, questions, comments before we move on to introducing Ms. Simpson.
I want to thank you again, Dr. Wolf. You really changed my life. It's so much better since I got rid of the atrial film.
Well, it was very helpful having you on because I think a lot of people did a double take. And I don't think they knew that I was doing the Minimaze 17 years ago. And some of them just thought, wait a minute, did he say 7 or did he say 7 months or did he really say 17 years? Of course, the answer is we really did say 17 years, didn't we?
Yes.
And I also want to thank you. I know you had some competing meetings this week and you were kind enough to come on to answer these questions. If you'd like to stay with us, that'd be great. If you can, I understand if you have to leave.
No, I'll stay with you.
All right. Okay. Ladies and gentlemen, again, this is DEBAKEY CV Live. We're coming to you from Houston, Texas Medical Center, the largest medical center in the world, and Houston Methodist Hospital, and the DEBAKEY studios. If you'd like to text us a question on your phone, go to 37607. That's 37607. And in the text box, type in DEBAKEY, DEBAKEY, DEBAKEY. And if you're on a computer, go to poll, POLL, E as in Elvis, V as in Victor.com/DEBAKEY. Debbie Simpson, as I mentioned, lives in the state of Washington. She has been an Army nurse. She's been in trauma, open heart, critical care. She got an advanced degree in as a nurse practitioner. She's worked in the Wounded Warrior Clinic. And she's kind enough to come on and talk to us and to you about AFib. She did have a Minimaze procedure, and she just celebrated her 1-year anniversary. I guess she's got 16 more to go to catch up with Godfrey. And I thought it'd be very helpful to have someone on who knows a lot about the medical field as a nurse practitioner. And the first thing I'd like to say to Debbie is, Debbie, thank you so much for your service. We really appreciate it.
Oh, my pleasure.
Tell everybody a little bit about your history. I know it, but in lay terms, this AFib thing, like many people, really started before you had a diagnosis. Is that correct?
That's correct. Yeah, I felt like a irregular heartbeat, like every once in a while. Kind of wrote it off to too much caffeine or anxiety or that kind of thing for I don't know how many years. And I currently work in the VA at the VA as a nurse practitioner and in primary care. So I see how they treat AFib. And so I had an episode where I was having this chest pain and a more regularly or irregular heart rate, more than I had just days. And so I did the thing I shouldn't have done. I listened to my own heart rate, and I could just tell by the way when I heard it, I was in AFib. Had my nurse do an EKG on me, which is another deal breaker. And I was in AFib with a rapid ventricular rate, hence the chest pain. So then I went to the ED to get taken care of there. So I was placed on medication, didn't tolerate, like I think a lot of women, there hasn't been this is my hypothesis. I think a lot of women, they haven't tested on some of the antiarrhythmics or beta blockers. And I think that, maybe the amounts are incorrect or the type of drugs they're using are incorrect because historically they haven't tested women. So I think women usually have worse side effects to the drugs as opposed to men. That's been my personal experience and what I see kind of when I treat people. So I didn't do well. I didn't have hypertension. I didn't have anything but a thyroid condition which placed me at a higher risk. So when I got diagnosed, went to the cardiologist, did the whole workup, everything was good. At that point had paroxysmal, like in and out of AFib. And then I think I then went into constant, persistent AFib. I went to a conference. I listened to all of the presentations at the conference about medication versus ablation. And then I heard you speak, and I'm a kind of a one and done kind of person. And what you had said made perfect sense from a medical standpoint to me compared to an ablation or anything else. So I didn't have any ablations. I was only on medications. Didn't want to wait. Was told by my physicians, just wait until you had symptoms. And that didn't really work because I know this is a chronic condition and that would change the architecture of how my heart was over time. So I felt that I needed to do something sooner than later. And when I heard you speak, it made perfect sense to me, the methodology and why it would work more. So I contacted the office and got a workup, and then, COVID hit. So put off and ended up, being able to have the Wolf Minimaze.
It delayed you for a little while, didn't it?
Yeah. And I was in persistent AFib probably 4 to 6 months before the procedure. Still on the medication for rate control, which dropped my blood pressure pretty low, which was challenging because it was a medication used for blood pressure, and that's not an issue I had. But the procedure was everything you said. There was no pain. The biggest hurdle I had was dealing with the side effects of the medication after the surgery. Mm-hmm. I was very thankful when I was off of them in a month. And what I noticed, prior to surgery, and because we had COVID, I was doing cardiovascular training because I knew I needed to do that to recover better. But I would say which was very unique. I was back to work in a month after the procedure, probably could have gone back to work after I was off the medicines, but in 2 weeks, really, to be quite honest. And I would say that what I noticed is I didn't realize how fatigued I was and how I was fighting my fatigue, just because I think my military mindset is just push through it, get off your butt, do it, until I had the procedure. And then my energy was much, much different, much different.
That's a very good point. Very good point. And that's very, very common. And it's because generally these medications when you have AFib are started out at a relatively low level, but when they don't work, the gut reaction is, well, let's double it. And I think you're also very right, especially about beta blockers in women. And I see some women come in and they're on 300 milligrams of a beta blocker a day. I don't know how they even get up.
Yeah. I had a very different, that and the antiarrhythmics, I could barely get off the couch. And I heard other women in this conference saying the same thing. And when I looked at the data, there's not a lot of women studied. And I went, and I hope, with the women heart disease thing, but I hope they study, like, maybe less is more for us. I don't know, but it was very interesting, not just the medication, being off the medication, but it's just like I was very taken back about 6 weeks after the surgery, how my energy level was back. I didn't have to think about, getting up and doing things or doing my normal activity. I'm very excited. I can go back to scuba diving. I'm a scuba diver. I can basically do the things I wanted to do. And, without hesitating because of the medications or because of the limitations by the AFib. I don't have any of those restrictions.
Yeah, it took me a while to understand this, Debbie. And the way I understood it was people were coming back after the Minimaze, like you're a year out, and saying, boy, this is the best I've felt in a long time. And I thought, well, okay, part of that's because you're back in rhythm, but the best you felt in a long time. And the answer was they're off all the medications, right?
Right.
And how about yourself as far as medication? You're 12 months out for the Minimaze. What do you take now?
I just take my thyroid medicine. That's it.
That's great.
Anything else? No anticoagulant, nothing else.
Now, here's an insurance question. I don't remember, but when you came to Houston, did you have TRICARE?
That was one of them. I had Medicare, so I'm divulging my age. I had Medicare. I had another, I had a PPO because I worked, like I say, for the VA. So I had like several insurances, but it covered everything. And not one red cent did I have to pay for this procedure at all. And even when I checked in to the gal who did the pre-op stuff, she was very reassuring, very knowledgeable. So it really put me at risk because I was prepared. Like, if that's what I had to do, that's what I had to do this. And, there'll never be for me. I know a lot of my cardiologist said, well, this is rather extreme for what you have. And it wasn't for me to do this procedure out the gate, no ablations, no nothing, because I knew what was unfolding from my medical background. And, there'll never be enough words for me to express, my thanks to you, thinking of other causative factors and other techniques to treat this condition, because nobody else has been thinking of that for years. And I don't even care if it came back, worst case scenario, there's other, like you said, there's other techniques that we can use. Secondly, still, I've been out of AFib for this period of time to give my heart a rest. And I also, never have to be on anticoagulation, so I don't have any of those limitations. So
that's another good point. What I tell people is if you are to have some irregular heartbeat after the Minimaze, it could be flutter or fib or whatever, you're protected because the left atrial appendage has been closed. So I know a lot of physicians don't understand this, and they immediately recommend blood thinners for someone who's had a Minimaze, but you don't need it. And if you look at the numbers, drugs like Xarelto, Eliquis, Pradaxa, decreased the risk of AFib stroke by about 60%. I think a lot of people have this misconception that if they take a blood thinner, there's no way they're going to get an AFib stroke. But in fact, we see AFib strokes on people that are taking blood thinners all the time. And you've probably seen it yourself as a nurse practitioner.
Yes.
And we know that if you stop the blood thinner but have the appendage closed with the AtriClip, you've decreased the chance of stroke by 97%. I think that's about as best as you can get, really.
Yes. Yes.
And
I also attest to the GI thing, is that I didn't realize that, but I was having like reflux kind of symptoms. But after the procedure with the AFib, they were really bad. So it's hard to say, is this my AFib and do I have a rapid, or is this just heartburn? But though you're absolutely 100% on the mark that those symptoms also went away with my AFib.
Well, that's interesting. I've heard that from many patients. I think there's an analogy. I could be wrong, but this is my take on it. And that is, back in the 60s, the most common operation in the United States was cutting out part of the stomach for ulcer disease. That was the most common operation in a regular community hospital. Then it was discovered that if you cut the branches of the vagus nerve that went to the stomach, that acid production stopped. So we stopped cutting out people's stomachs. Of course, now there are other ways to take care of ulcer disease with medications. But I think there may be an analogy with AFib. Burning up the heart's not the answer. Just like cutting out the stomach wasn't the answer. The answer is to go to where the initiators are, which are the nerves that are on the outside of the heart, specifically the autonomic nerves, which are mixed sympathetic and parasympathetic, the parasympathetic being the vagus nerve. And a lot of people have noticed great improvement in their stomach issues when their AFib is taken care of.
That's true in my case. I can attest to that.
Now, a question that comes up often is, and we know your way you went now, but the question comes up with many patients. My doctor has recommended that I get an ablation, maybe 2 ablations, maybe 3. And if 3 ablations fail, then maybe I should look for something else. Now, you didn't go that way. You knew that was available. As a nurse practitioner, you're very aware of that. So what was your thought process again? I think you touched on it a little bit, but just to reiterate and expand on that a little bit.
Well, my experience with caring for the patients, that's exactly what I saw, is they would get 3 ablations and they blow out their pacemaker AV node by the heart. And then they ended up by getting a pacemaker. And they still, even with the pacemaker, would be in AFib. Mm-hmm. So there's not that, it's like the stomach, like the example you gave with the stomach, but it didn't really correct the problem. And I just thought there's got to be a better way. And I figured, to address this, the AFib with, since ablations, they do one and 3 years later, they have to do another one, and 3 years later, they may have to do another one. And that isn't working. And that's very, people I knew in California that were thoracic surgeons and stuff like, they did a different kind of procedures, but other people in the community, that's just the way they do it on the West Coast. But like I said, when I went to this meeting and heard all the choices, didn't matter how the ablation was done. If it was done, if they did freezing, or if they did electro, or if they did, laser, no matter which way that was the methodology that was given, it's still the same outcomes were. And I mean, personally, I would hope, I know the electrophysiologists aren't going to like this, but I feel that maybe what would happen if this was the go-to procedure for AFib, and what would that give us in the long run? Would we avoid a lot of other things? I mean, I just think it should be the go-to thing. Personally, that's what, it just makes sense to me. Larger area, you do like you said, you do the nerves, there's more, the other way that, they've been doing it for years where they have to repeat it. So I was told that I was going a little bit too much too fast, but I think that this should be offered as a first line rather than the last resort.
Yeah, and that's the point. Go ahead, Godfrey. Did you have a comment, Godfrey? Make sure you're unmuted. And there's another part to that, which you and I have discussed, Debbie. Oh, go ahead.
Yeah. I'm unmuted now.
Yes.
I'm glad that she's got such good recovery there, similar to mine.
Yeah. Now, another point that we talked about, Debbie, was the fact that it's not just repeated ablations, but most people who've had repeated ablations never got off the blood thinner, and they never got off the antiarrhythmic medications, and they never got off the beta blockers or the calcium channel blockers. That's my impression. You've been in medicine for a long time, my guess more than 20 years. Is that your impression too?
Yeah, that's what I see in my clinical practice, because even though the patients have it done by the electrophysiologist, they come back to their primary care and say, well, I did this, don't I get off these medicines, which I usually, kind of defer to the cardiologist, but most often what I see is no, they don't. They remain on the anticoagulations. They may have a decrease in the amount of medications that they're taking as far as the strength, but not as far as the amounts. They're still on the blood pressure medicine, antiarrhythmic and anticoagulation medicine, and anticoagulate medication, but the strengths may need to be less, but they're still on those medications.
Which probably prevents them from really feeling normal, even if they're in rhythm.
Yeah, because a lot of them say that they don't really, they had it, they're told that they're in rhythm, but they don't really feel much different as far as their energy or their shortness of breath with the beta blockers that occurs, and so I try to explain that some of that's probably medication related, and they still can't engage in, some of them have done, some of them like stopped riding motorcycles. They're doing a lot of things they used to do, or even like not being able to work because the type of work they did, had to stop, which is devastating for them.
What I have recommended to people that I come in contact with who have AFib is look at all your options, understand what all your options are. Most frequently, they haven't been told about all their options. Correct. They've been told they can have a catheter ablation or an AV node ablation and pacemaker, but they were not aware that there are minimally invasive surgical options. And my recommendation is look at everything and go see an electrophysiologist, go see two, get a couple different opinions, but also get a minimally invasive surgical opinion and decide what's best for you.
And that's what I see here on the West Coast is they don't even mention that. It wasn't mentioned to me unless I went out and sought that information. I was really, I went through all the different types of minimal invasive kind of procedures. I researched that also. But I had no knowledge of this, and I've been, dealing with the patient population and then, had it myself. So it was news to me.
There was an article written by me just published in the DEBAKEY Journal. It's the DEBAKEY Cardiovascular Journal. You can get it online. Volume 17, number 1, the first 4 months of this year. And I have an article in there on the surgical treatment of AFib. And I go through all the different options for the surgical treatment of AFib. So for those in the audience, you might be interested in that. And I think we're trying to also get it on the Wolf Minimaze website. That's WOLF, mini, like little, and then maze, M-A-Z-E, wolfminimaze.com. Because I try to go, in that article, I try to go through all the different options. And there are options more than the Minimaze. But as far as I know, I'm the only one who really tests the nerves. And I think that's critical. For those of you out there that are watching, another little point is that 95% of all the AFib that's treated surgically is treated during another operation, another open heart operation, mitral valve repair, mitral valve replacement, coronary bypass, aortic valve replacement in patients who have AFib. Unfortunately, probably 30% of patients who have AFib and have to have open heart surgery don't have any treatment of AFib, which they should. But 60 to 70% now do have concomitant treatment of their AFib with their open heart surgery. And that's where the majority of the clamp use is. And that's where the majority of the AtriClip is. It's in open procedures in patients who are having other operations. But what we've been talking about with Mr. Klaber and Ms. Simpson is lone AFib in patients who don't need open heart surgery but have AFib. And this is a minimally invasive approach, minimally invasive surgical approach. But if you look at all of heart surgery and AFib, this is the small numbers that are done. I have been overseas many times. I have one of my fellows in Tokyo who sees patients from all over Japan and he calls it the WO procedure because his name's Otsuka. So he calls it the Wolf Otsuka procedure, which is fine with me because he's one of the few people I'd let do a Minimaze on me. He's very good. And then they're now doing about 500 of these procedures in China a year. I've made many visits to China to try to help them understand the lone AFib treatment from a surgical standpoint. So they're up to about 500 cases a year there, although I'm sure this last year it wasn't 500 cases. So we're trying to get the word out. But the key is to test the nerve. Now, Mr. Producers, I'd like to ask you, I didn't see any questions come up. Can you bring the screen up and tell me if we have any questions from the audience? We've got George and Fernando as the producers today, deep in the heart of Texas at our DEBAKEY studios in Houston, Texas. We had a little bit of issue with bringing up questions on the board. George or Fernando, if you're there, if there are any questions, if you could bring them up on my screen, then I'd be happy to repeat them and see if we can get some answers. The text is text to 37607, and then in the text box you put DEBAKEY, or you go to pollev.com/DEBAKEY. George or Fernando, any questions that we can attack right now? If you want to, you can put them directly up on my screen, if you're able to. Yeah. maybe they get to go home at 6 o'clock or, well, yeah. I mean, 6 o'clock Houston time. I'd like to ask you, you are still working, correct?
Yes.
And what are you doing now? You said you were at Open Heart at one. Oh, here we go. We got some. Let's take these. If you don't mind, Debbie, I'll go to these. Here's it's gone. It was up there for a second. I'm a fast reader, but I'm a really fast reader, but not that fast. How do I go to gallery view? This is a phone. Here's a person who says, I agree, first resort, not last. I don't want to have multiple ablations and all these medications. Next one is, what are your thoughts on beta blockers compared to sodium channel blockers? I switched to metoprolol from diltiazem and feel blah. Well, Debbie and probably Mr. Klaber, you can answer that one. Beta blockers really slow you down. That includes sotalol with an antiarrhythmic. And Debbie, I think you told me you couldn't take it at all.
Right. I mean, the beta blocker I was on, and they switched me actually to the calcium channel blocker.
Was that a little better for you?
Yes, it was. I mean, it controlled the rate, not as well. I mean, it controlled the rate and had less side effects.
As you know, one of the side effects of calcium channel blockers is swelling of the lower extremities. Not everybody gets it, but some people get it pretty severely, and then the calcium channel blocker has to be discontinued.
I mean, I had a little bit, but I like make sure I drank enough water and watch. And I was on a real high dose. I mean, they were increasing the dose to keep the rate under control. But
now that's Mr. Producers. If you go back to the screen for a second that had the questions, and we'll tackle. There you go. If you drive from out of town, how long of a stay would it be in Houston to allow for the entire process? Well, it's gotten a little bit longer post-COVID. So everybody has to get a COVID test. We do that about 2 days before the procedure. Most people come into Houston on a Thursday. We see them Friday in the office. Usually the only test that's needed is a CT scan, which is about a 20-second scan, which shows me the anatomy of the left atrium, which is very helpful. It's a very quick test, but it also shows me the coronary arteries. We had a gentleman come in from Hawaii, and we did the CT scan the day before, and turned out he had a major blockage of a coronary artery, and he passed his stress test, had a negative stress test, but we end up doing a stent in one of the arteries, and we're going to see how he does from that to see if he still has the AFib. So this 20-second CT scan that we do at Houston Methodist is extremely helpful in looking at the anatomy and also the anatomy of the coronary arteries. Okay, let's go back to take another question. Okay, how often would you say that you need to go back after the Minimaze to do an ablation? Well, if the patient has intermittent AFib, it's extremely rare. But if they've been out of rhythm for more than a year and have an enlarged left atrium, I mean very enlarged, then it's about 20 chances out of 100 we may have to go back and do an ablation. It's probably less than that, but maybe 15. We don't do that many. As I said, they've been very successful. But if you have persistent or paroxysmal meaning you go in and out of AFib, you don't have it all the time, or like Debbie, you have it continuously, but it's been continuous for less than a year. Very rare to have to go back to do an ablation. Next question is, I find eating can give me AFib. After the Minimaze, will I be able to eat more normally? Well, in general, the answer is yes. And I think Debbie touched on it a little bit. Debbie, you want to answer that one?
yes, I found that I would have like reflux or heartburn symptoms with my AFib. After the surgery, those went away. So I think it was more my AFib than it was heartburn.
Yeah. Now, some people have both. I even had one patient within this last year who had AFib and a very large hiatal hernia where half of her stomach was up in her chest. So in that lady who had continuous AFib, we did the Minimaze first. She had no more AFib. We waited about 8 months, still no AFib, off all her medications, and then went back with the Da Vinci robot. And my colleague at Houston Methodist, who's a whiz at this, did a Da Vinci robot, minimally invasive hernia repair, and put her stomach back where it should be, down in her belly and not up in her chest. So we do see that occasionally as well. Mr. Producers, any more questions on the screen
Dr.
there?
Wolf?
Yep.
Dr.
Yes.
Wolf,
Yes.
I would like to comment on that last question.
Please do.
It seemed like so many foods that I would try to eat would cause atrial fib. And I was continually walking a tightrope, trying to avoid certain foods that gave me atrial fib. After I had the operation, I could eat almost anything. It was
That's
really a nice side effect.
Yes.
I'd be happy to take credit for that. That's really a great comment. Debbie?
No, I'm good. Like I said before, I could eat anything afterwards. It was better.
which could be good or bad, right?
True. Very true.
Let's go back to the questions and see what else we got here. Can you repeat the reference to the magazine publication you just wrote? Yes, of course. This is DEBAKEY Cardiovascular Journal. It comes out quarterly. You can find it on the Houston Methodist website. You can also probably find it on DEBAKEY CV Journal. C as in Charlie, V as in Victor. DEBAKEY CV Journal. I would look at Houston Methodist website for the journal, or you can go directly. I think there's a website for the journal, and it was this most recent issue, which I believe is volume 17, number 1. And the last article in the magazine is the article on the surgical treatment of AFib, where I discuss all the different treatments for AFib with any type of surgery. It's a pretty good overview, and I tried to write it. I did not write this for other surgeons. This was written for regular docs and for the lay public. Next question, George or Fernando. Let's see. What actually is done to the 2 nerves you talked about? Well, what I do is I figured out a way, working with some researchers at University of Oklahoma, Dr. Ben Sherlog and Dr. Sonny Jackman, that you could stimulate the fat pads on the outside of the heart. And you could tell where these nerves were by the response of the heart. And as it turns out, if you hit a vagal nerve branch, the heart will stop while you're stimulating. This is a tiny electrical stimulation. You can't even feel it on your finger. And we were the first ones to do this in the human. And then when you stop, the heart comes back. So we burn those areas with a special pen, and then we test again. And then we find that we test and give high frequency stimulation to that area. There's no response. That's how we know we've taken care of those tiny nerve endings in the fat of the heart that come from the vagus nerve. The other is the sympathetic nerves. And this is explained in my article with some diagrams. Again, that's the DEBAKEY CV Journal this past month. Next question. I've had cryoballoon ablation for AFib and RF ablation for a flutter. What if those didn't keep the electrical signals from jumping inside my heart? Would a Minimaze? Well, of course. You see, my point is that I have a fundamentally different approach to AFib, and that is go for the initiators. Don't burn up the heart. Don't freeze the heart. Whenever the heart is burned or frozen, those cells die. Those heart cells are dead, and they never come back. They're gone forever. It's not the solution, because these burns and these freezing areas hardly ever get out to the outside of the heart where the nerves are. So the nerves are still firing. They find a little path around the burned area, around the frozen area, and they still initiate AFib and a flutter. The key is the outside of the heart and the clamp, which gives a transmural line. So I have done, well, about half the patients I take care of have had cryoablation, radiofrequency ablation, or both. Unfortunately, I've had the experience of doing the Minimaze in patients that have had 6 ablations. The Minimaze still works. Sometimes it's also the left atrial appendage that's the cause, which is very hard to ablate with a catheter. Let's go back to the questions. So total days in Houston is, okay, I didn't finish that. Thank you. And another one is, if I fly down, how long do I stay? So both related questions. And you're right, I didn't finish my answer there. I got off track. So usually if the patients come on a Thursday, get the CT scan on Friday, and the procedure's on Monday, most of those patients will be back in the hotel on Wednesday. They stay in the hotel the rest of the week, come back and see me the following Monday, and most of the patients get a link a subcutaneous monitor so we can monitor their heart rhythm at home. And they either leave that day or the next. So it's usually 10 or 11 days, Thursday, Friday, Saturday, Sunday, Monday, Tuesday, Wednesday, Thursday, Friday, Saturday, Sunday, Monday. That's about 12 days. That's if you come and get the COVID and everything else. Now, there are people that live, 3 to 4 to 7 to 9 hours away that will drive back home and then after 2 weeks come back. But if you're flying in, it's the better part of 10 to 12 days. Now, some patients have gone back earlier. An attorney in Chicago who was on this program several months ago went back a few days after her Minimaze, drove herself home from the Chicago airport, and went back to work in a few days. So you can do that, but I don't recommend it. I think it's better just to stay in Houston till you're about a week after the surgery, so I can see you, make sure that everything looks okay, and then it's very safe for you to get back on a plane and travel home. We also have some people that drive from as far away as California, or one fellow came from Oregon. He took the train. That's within the last couple of months. Some people will bring their RV. There are some really very nice RV parks within a couple miles of the complex. And those RV parks also bring patients to the Texas Medical Center, no charge. But I think overall, people have been most happy if they make this sort of a medical tourism journey. And a couple of the recent patients have put onto paper, so to speak, what to do in Houston. And you can get to that at the Wolf Minimaze site. This is on Facebook. It's called Wolf Minimaze. And there's some really detailed things about what to do while you're in Houston. Some people go down to Galveston for a few days. Some people go to the Art Museum, the Museum of Natural History. A couple of people went to the Undertaker's Museum. I don't quite understand that, but I'm sure they had good reason to do that. But there are about 20 museums that are a mile or two from the medical center. So many patients will do that. The Marriott, by the way, is connected to my office. It's connected to the hospital. A lot of patients stay there because they don't have to even go outside to reach either my office or the hospital. That's right next to the Westin, which is right next to the Intercontinental, which is right next to the Hilton. So they're all right there, plus many, many others. But I found that people are most happy if they just stay for 10 or 12 days, go see the sights of Houston while they're recovering, and then see me a week after surgery. Next question. What if I already have a link? This is a subcutaneous monitor, and if you have a link, you don't need a new one. Do you always prescribe Ambiodrone after the Minimaze? The answer is no. And another question is, what do other cardiologists, why do they not agree the vagus nerve has anything to do with AFib? Well, I think they don't agree with it because they can't get to it. And if they can't do it, then you don't need it. As far as the Ambiodrone, the answer is no. I prescribe Ambiodrone for people who have been continuously out of rhythm for 6 months or over a year. But in patients who've not been out of rhythm or still have intermittent AFib, I don't routinely prescribe Ambiodrone. And the last question we'll end with is for both of you, both Debbie and Godfrey, and that is pain level after surgery. And Debbie, I'll take you first. Please answer the question, pain level after surgery.
Well, it was very minimal. I had one night that literally you're kind of numb from the nerves and everything from one side to the other. And I really, to be honest, pain wasn't my issue at all. I had one night that how Dr. Wolf treats your pain preoperatively and during the surgery is spot on. Because when I understand the meds he was using, I'm going, really, you're going to use that? And it works because he gave me some pain medication to take for my trip home if I need it. I never, ever use it. It's true what he says. You don't need it. I had one night that things were kind of cranky and my nurse and the night nurse there and the nursing staff and the staff at the hospital is amazing. And she just said, well, you're just like not getting a lot of sleep, and I'm going to call him. And I just told him, never mind, because this too shall pass. And it wasn't, I'd say that night it was maybe a level 6 if it was that. But there was like literally my challenges was with the side effects of the medication. There was not pain. I was out walking when I got released, out and about Houston. My friend was rather amazed that was accompanying me, but my pain level was not an issue at all.
Godfrey Klaber, would you care to opine?
Yes, pain was not a problem for me. It was pretty easy.
Yeah, I agree.
Before I go, I would like to thank you again, Dr. Wolf. You made such a gigantic change for the good in my life, and it's really been a great pleasure to know you. And I thank you again.
And I thank you for coming on a second time to finish up. You did your good deed for the day. Debbie, you do your good deed every day, taking care of wounded soldiers and working in the VA. And we all owe you a debt of gratitude for sure. I want to thank you both for joining us for this session of DEBAKEY CV Live, Dr. Lumsden's creation, which gets the word out to patients. You've answered all the questions very well. The last question is, if you're willing to share your email, if somebody would like to contact you. And I told you before the show, you don't have to, that's up to you. We don't want you to give out a telephone number, but Debbie, you first. Is there an email you'd like to share?
Yes, my email is deb_scuba, like scuba diving, SCUBA @yahoo.com. And I'd be more than happy to answer any questions or concerns at all to help spread the word about this procedure and how life-changing it is.
Thank you. Would you repeat that one more time slowly for people who didn't have their pen ready?
Yes, it's Deb, DEB_scuba, SCUBA @yahoo.com.
Thank you. Mr. Klaber, I think you gave yours out last month, but if you'd like to repeat it, that'd be great.
Yes, it's Orange, ORANGE 6527 @yahoo.com.
Another yahoo.com, but please repeat it one more time.
Orange 6527 @yahoo.com.
I want to thank George and Fernando, our producers, for putting together this different people in different places and doing a fantastic job. I want to thank all the people who listened in and sent in questions. Your questions were excellent and helped us get to some points that were important to make about AFib. We'll be back again in 1 month. I take it back. I think George and Fernando, isn't next month a month off? Isn't that your summer vacation? It might be. So July, they may take a rest. These guys work day and night, so they get 1 month a year, so they don't have to work this late at night. So I think we may be back after a summer break. If you want more information, you can go to wolfminimaze.com. There's a lot of information there. You can also go on Facebook to the Wolf Minimaze site, which is a private site, but I'm sure the administrator would be happy to have you in the group. That's Wolf Minimaze on Facebook. Until probably after the summer break, I hope everybody has a great summer. It's been a phenomenal spring in most parts of the country. Everybody get out and enjoy it. And if you have AFib, give us a call. Thank you all, and goodbye from DEBAKEY CV Live.
Thank you.